Hello, everyone. Welcome to NYC Builds Bio Virtually Quarterly Breakfast. Thank you so much for joining us this morning. My name is Nancy Kelly, and I serve on the steering committee and as a founding member of NYC Builds Bio. I want to thank our hosts and sponsors of today's meeting for their generous support. They are Ennead Architects, Hayworth, EJ Electric, and Ashnew International. I would also like to thank the founding and corporate members who make this programming possible. This is the first of four virtual events hosted by NYC Builds Bio this month. If you haven't already, please check out our website and register to participate. On May 19th, in collaboration with Genetic Engineering and Biotechnology News, we will be discussing the top COVID-19 drugs and vaccine candidates, together with 3 New York companies who are working on those projects. On May 21st, in collaboration with BioCentury, we are hosting a networking reception for current and prospective members, which will include a discussion around the business and financial prospects for the life science industry post-COVID-19. And on May 28th, SGA will host the first program of our newly launched virtual seminar series, also in collaboration with Genetic Engineering and Biotechnology News, entitled Life Science Facility Planning Post-COVID-19. Originally, our May quarterly breakfast was to include a discussion around exciting new developments contributing to a medical and scientific renaissance in the Bronx, focusing on the Einstein Medical College and the Hutchinson Metro Center. Due to the impact of COVID-19 on Einstein Medical Center, this agenda has been postponed and will be presented on September 17th at our fall quarterly breakfast. This morning, our agenda will focus on the COVID-19 crisis and the heroic efforts made by New York City institutions and many of our members to create the personal protective equipment, tests, and facilities to save lives. Facilities of every kind, ships, hotels, tents, a convention center, and hospital spaces were evaluated, repurposed, and pressed into service as makeshift hospital facilities, and paused commercial construction projects became emergency commercial construction projects. The program provides a firsthand account of what happened, how companies and institutions responded, and the projects they worked on. Before we begin, I just want to cover a few administrative details. There is a program and a PowerPoint highlighting the hosts, sponsors, speakers, and projects for the meeting. This will be posted on the NYC Builds Bio website after the meeting. The program is being recorded and will also be available on the website and the NYC Builds Bio YouTube channel after the meeting. If anyone is having technical difficulties accessing the Zoom room or other technical issues, please email info@nycbuildsbio.org or send a notice through the chat button at the bottom of your screen. Since most of you are participating in listen-only mode, please feel free to submit your questions at the Q&A button on the bottom of the screen. We will open up for discussion and Q&A at the end of the program and will address as many questions as possible. And now I will open it up to Rich Steimel and Chuck Richmond of Lend-Lease to begin our program.
Well, thank you, Nancy, and good morning, everyone. I want to thank you all for taking the time out to participate in this unique event. It's certainly quite a departure from what was originally planned, but Nancy and Mitch have put together a pretty remarkable group of individuals that are going to share their stories. And I'm lucky enough to start it off. And my name is Rich Steimel. I'm the principal in charge of the healthcare group at Lend-Lease. My coworker Chuck is going to follow in just a couple of minutes. And what we'd like to do is share with you a few of the details of some of the emergency work that we did at various healthcare providers throughout the city. And I'd like to point out that initially, you'll find out that there were several common needs throughout these various projects on various campuses. In no particular order, it was a goal for across the board really to add additional beds to the facilities, to reverse the pressurization in the spaces from positive to negative, number two, and also creating screening areas. And these screening areas were for both the workers as well as the potential patients. Now, in addition to those three common threads across the projects that we provided, there was something else that may not be quite as tangible, but it was real. And that was the highest level of collaboration that I've personally ever witnessed amongst all the people involved. And I mean that for the vendors, the subcontractors, the builders, the workers themselves, our design partners, and the client. Across the board, the level of cooperation and flexibility was nothing less than remarkable. And you could see that it was a team effort. And I walk away hoping that future projects can take that spirit of cooperation and carry it forward. Now, for my first slide, if we could do that, I'd like to show you just a pretty simple addition that was made for 6 regional outpatient campuses for one of our clients. The idea was that trailers were required, or at least that was the idea, was to get trailers on 6 different outpatient campuses to allow the workers to be screened prior to walking into the physical campus themselves. So our client had reached out for us with a simple phone call to understand the practicality and viability of having this need met. And it was just 8 days later that these trailers were physically in place, functioning, and 100% online. Again, it was a reflection of an entire team from top to bottom and across the board, willing to work together, put aside any sort of differences, and reach one common goal. So it was a complete success, and it did contribute to the ability of these facilities to operate. Now, moving on to the next slide, we have our partner up at New York Presbyterian, where a series of projects were undertaken on an immediate basis. And it was along the lines of what I mentioned earlier about the need for additional beds, converting spaces and repurposing areas, and converting and reversing the pressurization. Just a couple of quick examples. The existing operating rooms were converted actually into a space to accommodate 60 beds. And you can see with the temporary measures that the HEPA filters were installed on a temporary basis to reverse the pressurization to negative. In addition to that, we actually took whole bed units, 5 bed units for a total of 150 beds. And with some pretty quick action on the behalf of our suppliers and vendors, we're able to procure some large 10,000 CFN fans, rooftop installation, mechanical work done on some of the patient floors. And that allowed typical med-surg beds to be functioning to address the needs of the surge in the virus. In addition to that, on a much more temporary basis, there were surge beds added in spaces and real estate that was available outside your normal clinical space within a large healthcare facility. So as I said earlier, the need for additional beds, reversing the pressurization of the areas, and creating screening areas were to become a reality with, again, a great level of cooperation throughout the board from the client on down the supply chain. So wanted to share that with you. And with that, I'd like to introduce my coworker, Chuck Richmond.
Thanks, Rich. If I can only add to what Rich said about cooperation and collaboration, it really is a sign of what can be done. So my name is Chuck Richmond. I'm a Senior Vice President and Operations Director for our Healthcare Division at Lend-Lease. And I'm going to give you a quick overview on 2 projects. If you can change the slide, thank you. So the first project is the Methodist campus for New York Presbyterian. So they had an existing 34 patient behavioral health space, about 18,000 square feet, and they asked us to convert it into ICU beds. Because it was a behavioral health space, it had some very hard walls and ceilings, so a lot of the infrastructure needed to be run surface mounted. But we converted, 34 rooms into 61 ICU beds. So you needed all new med gases run from the nearest risers, all new normal emergency power, new panels, HEPA exhaust fans installed at the windows you can see on the left to create that negative air that Rich was talking about. And it was the same type of thing. So it was just, negative air, new infrastructure from wherever you could get it, tapping into power sources to add new panels. This particular space required some architectural renovations as well, since it was a behavioral health space. We had to change some things like some door hardware, for example, needed to be retrofitted. Again, with the cooperation of the subs, the vendors, the design team, and especially the client, this work was performed in about 14 days. And as we were literally sweeping up, the last room, they started rolling in patients on the other side of the floor. So it was pretty rewarding seeing how desperately they needed it and how quickly the team could mobilize to satisfy that requirement. So if you can move on to the next slide. Thank you. At NYU, we had a couple different tasks, including creating a screening space, like Rich mentioned. That seems pretty common. We also were asked to help participate in creating a field tent at their ambulance drop-off to the emergency department. So this pictures show an 1,800 square foot tent. It's got 14 bays, includes medical gases, normal emergency power, a fully functioning HEPA filtration system. It's sprinklered, has working potable sinks with dedicated pumps, even has an isolation room. So this request came, a couple days before the work started, and it took 10 days to get up and running. It's truly remarkable, and another quite very successful story. Also at NYU, we're currently participating in a permanent expansion to their existing emergency department. They're adding 10 additional treatment bays, 4 isolation rooms, nurses station, the associated support spaces that go along with that. It's a 2-story space. The second floor is going to be used for storage as well as easy access for the MEPs that feed the space below. This work is scheduled to be done in about the next 3 to 4 weeks and will be operational in June. And just to reiterate what Rich said about collaboration, these projects don't happen without daily meetings. They first started on site, like a typical colo. Then they turned to basically virtual, except for us, we're still on site. But everyone participating from the design team, the clients, the subs, really everyone pitching in. It's quite a successful effort, and we're really happy to have been able to participate in this. So with that, I think I'm going to turn it over to the next group.
Hey, good morning, everyone. My name is Chris Proctor. I'm a senior partner at Jarvis Bauman Bowles Consulting Engineers. And first off, I'd just like to thank Chuck and Rich for all their hard work and their efforts over the last couple of weeks. Amazing work, gentlemen. So I have 120 seconds to talk about what seems to be a lifetime of work over the last couple of weeks. On March 16th, the governor or the nation quarantined themselves, and the governor reported on a daily basis that cases were increasing daily, deaths were increasing daily, intubations were increasing daily, and most importantly, the needs for beds were increasing on a daily basis. Next slide, please. So we had a number of meetings with a number of folks, the Turners of the world, the Lend-Leases of the world, architects, other engineers, on how can we help this effort in this pandemic. And it wasn't until we got the phone call on March 28th, it was a Saturday night. I got a call from Turner about 10:30 at night saying clock starts Sunday morning at Stony Brook. So 7:30 a.m. I show up and the clock started ticking. We had 72 hours to turn things around and have a complete set of design documents. So it took the first 24 hours to call everybody early on a Sunday morning, 8:30. I'm calling my team members to get a mechanical engineer, electrical, plumbing, fire protection, fire alarm, information technologies, and field engineers lined up, ready to go for Monday morning. Monday morning hits, and we had a whole team in place and all ready to go. All the contractors are there, all of the engineers, architects, design team, everybody was in place. Next slide, please. So what you see up here looks like a typical timeline for a project, only it took, it's a little bit more condensed. We had 21 days to finish this effort. The program was to build over 1,000 beds. So again, 24 hours to mobilize, understand the program that the Army Corps of Engineers had assembled for us, really understand all of the particulars, design, 48 hours, get it done. And I couldn't wait for the architect to, give me layouts for nursing stations, patient spaces, et cetera, et cetera. We just had to go on certain metrics. We couldn't get U values for the tent fabric. So we had to do a lot of research to do our heating and cooling load calculations, translate that all into electrical calculations so we could size our generators. We didn't have utility power on the site available to us in an easy way, so we had to arrange our generators in a normal, one generator acted as a normal power source, and the other generator would act as a emergency power source. So going through a procurement, things aren't just laying around. We actually had to secure 45 50-ton air-cooled air conditioning units literally in days. And I'll talk a little bit about that in a moment. We needed 10 2-meg engines. We needed power distribution units. It's just all these materials needed to get procured in a very, very quick manner. Logistics. We had to meet with the Army Corps of Engineers. We had to meet with the facilities folks. We met with the coaches on, I believe it was Tuesday, the second day in, and where we were planning on putting 4 tents on the baseball, football, track and field, and soccer fields. They all said no, so we had to go into the grassy areas on the campus. So having a shift from 4 tents, we couldn't quite fit everything into the area, so we had to squeeze a 5th tent out of it. So bringing everybody together, everybody was collaborating and working as a team towards this common goal and really shifting on the fly. Shop drawings were done. We would sit with the contractors and draw things in real time and update our design drawings to match shop drawings. Coordination on a daily basis. We were quote unquote flattening the curve. For every one answer, we have 10 more questions. And as days went by, we were able to lower those 10 questions. For every one question, obviously we would get it down to near 0. Same thing, construction management and quality management. On the fly, the original program called for non-COVID beds. Then the medical center came in and said, hey, you know what? We need a couple of these tents to be for COVID patients. We just don't have the volume of non-COVID patients. So we had to make another quick shift on HEPA filtration, and air change rates and the like, and electrical power to all of the spaces to support ventilators. So it was constant change management all the way through the project, and it couldn't have happened without a real team effort by all the design team members and build members of the team. Testing, commissioning, our field guys are out there on a daily basis working 3 8-hour shifts, real time answering questions in the field. The forms were developed as we were designing the project, so this way at the end of this effort, we were able to just go through things as quickly as possible and get things tested and signed off. We balanced all of the units, we tested all of the engines, and the turnover was actually on Saturday morning, April 25th. Truly an amazing accomplishment by all. Next slide, please. And the last item I just wanted to bring up was there was where do you secure 45, 50-ton air handling units to support this space? And that was just for Stony Brook. I needed another 45 over at SUNY Westbury. And what happened was this particular manufacturer stepped to the plate, cleared their entire assembly line of all active projects and built units just for these 2 tents. We ordered them on a Tuesday afternoon. The first batch of units started showing up on Saturday. So tremendous effort by all those involved, the team members from the builders, the designers, the engineers, the architects, the structural folks, and the manufacturers. Everybody really stepped up for these tent projects. I'd like to pass it on to John Koch, my partner at JB&B, to talk about the next slides.
Thank you, Chris. And while the alternate care facilities were being built, as Chris just described, all existing institutions were asking themselves, how do we leverage existing infrastructure? How can we modify patient rooms to handle the increased patient volumes that all the institutions around the New York City area were experiencing? So there were multiple campuses that took a look at their infrastructure planning, and based on infrastructure that was in place, how could that infrastructure be easily adaptable? How do we get more capacity out of the systems? How do we get systems to serve other areas within a hospital or a campus setting to either increase the patient volumes or increase the amount of rooms? And then after the infrastructure side was solved, the institutions then looked at the actual patient room. Normally acute care rooms, how do we take an acute care room and how do we flex that up to an ICU room? Or given this current pandemic and the need for the increased amount of medical gases, particularly oxygen, how do we adapt the patient room that we have and the head wall we have currently to add additional oxygen outlets? And then the last thing that the institutions also looked at is the resiliency and the redundancy that you effectively have within a hospital. And how do you take those N+1 systems, the N+1 exhaust systems, the N+1 air handlers, and how do we modify those systems so this way you can get additional capacity out of those systems to meet the additional patient volume demands? So all these things were looked at. So this way you can come up with a facility that could handle increased patient volumes without having to rely on procurement processes and trying to secure equipment that requires long lead times. It was all about speed to market and converting existing assets to handle the patient volumes and demand. With that, I'll hand it back over to Nancy.
Hi. I'm Tony Mann, and thanks, John and Chris. I'm going to talk a little bit more about Stony Brook. I'm president of EJ, and as Chris started to mention, we all jumped in on Stony Brook. We had done during Sandy, got hospitals up in 3 weeks, but this is building 1,000 beds in 21 days. It was unbelievable. We went from 0 to 320 electricians in 7 days. We got up to 320. Never in my career have I heard of anyone doing it that quickly. And on site, we had over 20 project managers, engineers, and administrative staff. And this project including losing a day to windstorms. The key that from the contractor's perspective that we see is that it's design build, the teamwork, prefab, safety, and procurement. I'll start with safety. Yes, we had full-time safety job like most projects, but the key here was the COVID-19. Everyone had glasses, masks, social distancing, because we had to keep everyone safe, and it was a success. On teamwork, the difference I saw here was senior leadership. Whether it was JB&B, Chris, Turner, key senior leaders from their whole team. The Army Corps had senior people. We all had people that can make decisions instantaneously, and it was a true partnership. On the design build, we were all inside the arena. 10 feet to the left was JB&B, 10 feet to the right was Turner. Everyone, if you had a question, could get it answered right away. And that's what, design build is all about. We took an approach making it a deck job. There was a floor built, wooden floor, where we ran all the branch conduit underneath, the IT cable, the HVAC went around the tent. But the advantage was that we were able to stub up early. And so when we were going to finish, we were already there with all the branch conduit and just doing finished work. We also partnered with Johnson Controls on all the systems. And if you can imagine, Chris was talking 5 tents, 1,000 beds. You had in each tent fire alarm, nurses call, CCTV, your IT and data, your voice over IP. All these systems, all up and running, commissioned in 21 days. Chris was talking about some of the amazing things that they were involved with procurement. And, the things you don't see, every vendor dropped same day delivery. We needed something, it was same day. If we couldn't, we had a manufacturer up in Connecticut. Actually had my daughter go up at 8 a.m. when there were 60-mile-per-hour winds coming later that day to get the connectors in that they were manufacturing so we could keep going. The switchgear was made in New Jersey. They were working around the clock, 24 hours a day. And we actually sent people out there to help them wire up the switchgear because they needed assistance, and that's the way these projects go. Everyone helps. One other thing with procurement we learned, which is a lesson for the future for everyone, is the Army Corps of Engineers does not rent, they buy. So the design was originally done around some rental generators. Then the Army Corps says, no, we only buy, had to redo it, done instantaneously. JB&B jumped in and redesigned what needed to be done. And the last thing I wanted to talk about was prefab. As you see on these projects, to get that done in 21 days, we needed to prefab, and we came up with a pole that had normal life safety, all pre-drilled, all the connectors on it, switching next to every bed. So you can imagine 1,000 of these poles. If you didn't have those come in, what would have had to be done? 1,000, we were already at 320 electricians. Couldn't get these things done on time without that. And also the fixtures. So normally we'd get them finished how we want them in the factory. Because of the time constraint, 1,000 fixtures for 1,000 beds, we got them on site, set up a prefab facility there, and pre-whipped them, put in hanging brackets, tied them into the power poles, and we're able to expedite the whole thing. And the big advantage of prefab in this COVID-19 situation is that social distancing. You're able to have less people out there working around each other. And as we go get back up and going in the construction industry right now, you're going to see these lessons learned on prefab continue. We have a prefab shop that we use regularly, and this is becoming more and more important for everyone to think through what you can do in prefab to keep social distancing, to keep everyone safe as we go back to work. So thank you. I'm going to turn it over to Peter Santella with EJ. Thank you.
Good morning, Tony. Thank you. Could we just turn put the slide on New York Presbyterian Allen Hospital, please? Thank you. Good morning. My name is Peter Santella, Vice President of Healthcare at EJ Electric, here to speak about our New York Presbyterian Allen Hospital project. Adjacent to the hospital is Columbia University Baker Athletics Complex, which houses a 90,000 square foot domed soccer field. NYP's senior leadership decided to construct a field hospital for patients with mild to moderate COVID-19 symptoms within the dome. The basis of design, 288 beds, 16 nurses stations, 2 crash tents, generator power, and oxygen were required. Our goal to complete the project in an unprecedented 168 hours. Contracting method was design build. Within 24 hours, 3 500 kW generators configured in an N+1 system with switchgear were sourced. Custom frames were constructed to manage and distribute the generator cables. In the photo on the left, a concerted effort to create the common support bracket used above bed pods for branch power circuitry, oxygen piping, and communication cables. The timeline from whiteboard to prototype to final design, manufacturing, and product on site was 48 hours. Teamwork and collaboration prevailed. EJ's prefab shop built 400 quad receptacles with branch circuitry and the power panel unistrut assemblies. Inside the dome, the challenge, no overhead supports. Creative engineering solutions were used to design floor mount stanchions and aerial guide supports. Safety, 0 accidents, working 24/7. The bottom right photo depicts the completed project. A trusted partnership, a strong sense of urgency, laser focus, streamlined decisions, and operational excellence was the recipe for success. A final thought, how can we take our lessons learned to fast track and build the efficient lab spaces needed to support scientists in finding treatments and vaccines in the new normal? Thank you, and I'd like to turn it over to Chris next.
Good morning, everybody. My name is Christensen. I'm a construction executive with Turner Construction Company. My project that I've been working on for the past 2 years has been at Coney Island Hospital. And as you can imagine, the Health and Hospitals Corporation of New York City bore the major brunt of all of the treatment for C-19 in these past few months. Being here and establishing a relationship with H&H, we were able to put a contract into place that allowed us to start very quickly. And with the partnership of JB&B, EJ Electric, Perkins Eastman, and many others, we were able to contribute right away to getting extra beds in place at a few of these facilities. The first one was a tent at Coney Island Hospital. And you can see some of the pictures of the tent. It was laid out in a very dense way, a very open space planning way. But just to have the leadership working with the hospital team, establishing what the need was, having a well-defined vision of what the space wanted to be, allowed us to work together with the client, lay out the space, and get the densest ability to put patients in beds in the quickest way possible. The majority of the work was performed by EJ Electric. They came in and they provided power in a very prefab and expedited way. We worked around the clock, and within 1 week, we were able to turn over 78 beds for use. These beds were originally supposed to be just overflow for the existing hospitals so they could make space in the existing hospital for C-19 patients. But immediately, we finished on a Sunday. That Monday, there were C-19 patients in the space being treated by the hospital staff. Concurrent with this work, the team that we assembled, we established a partnership early with JB&B, with EJ Electric, with Perkins Eastman, and a whole host of other companies. We were asked to go around the city and do some major assessments for some other spaces. Down at South Street Seaport, there was an empty commercial office building that was examined, nursing homes up in Rockland County, some work down at the Allen Hospital. All of this needed quick thinking, professional work, and assessment to make sure that it could work or it couldn't. Some of them could not work, many of them did. Another one that was able to move forward was Kings County Hospital that Peter just touched on. Right there, we were able to take another 78 beds in an existing behavioral health building. And with the addition of oxygen and electric, we were able to convert within a week and a half those 78 rooms into med-surg spaces. So 78 beds were added on that project as well. Keeping it simple, having a good vision, having strong leadership, and a well-defined ending is what helps these projects succeed. As this presentation was being prepared, we were actually given 2 new projects, another one at Coney Island Hospital where we are adding over 100 beds in existing administrative space, and we find ourselves back at Kings County adding another oxygen farm and reinvigorating some other spaces in the behavioral health building. So again, it's the contracting, it's the partnerships that allowed us to step in and make a big difference right away. So I want to thank all my partners. I want to thank our clients, and I'd like to turn over the presentation back to the Berman Group. Thank you, everybody.
Good morning, everyone. My name is Eric Vieira. I'm the Director of Strategic Collaborations for Columbia's School of Engineering and Applied Sciences. I want to thank the organizers and the sponsors for giving us an opportunity to talk about how a university got involved with the early response to the COVID-19 crisis. Not many people think about turning to an academic institution for support, but at this time, I think our collaboration, particularly with the Columbia Medical Center and New York Presbyterian, will show the benefits and the opportunities and the resources that are provided. So today I want to describe to you about a new innovation unit that I helped coordinate with the School of Engineering to support the urgent response, particularly focusing on technological solutions that may be needed by our frontline clinicians up at the medical centers. It all started in early March. If I can have the first slide, please. We were slowly ramping down our research at Columbia, sending our students home, and all of our faculty were closing up their research laboratories and halting their research on orders by the governor. However, we continued to want and looked for ways to support the effort as we heard the crisis getting more severe in New York City. And it all started with this email one of our colleagues received from a clinician up at the medical center. As you can see, it was dated March 18th at 9 p.m. So these were, situations were changing drastically, all hours of the day. And it came through as a crazy idea. It said, can you or anyone in your department 3D print a surgical mask? And if so, can you print 1 million of them this weekend? They turned to us because the engineering school has facilities. We've built out a very new makerspace with lots of 3D printers. Our library has coordinated efforts throughout the university to have 3D printers available. So they knew that we had the capability, and other universities were starting to get involved with 3D printing of these shields that we eventually started with. Next slide, please. So we put out our bat signal, in essence, our own version of a bat signal, par for the course, I guess, given that this was a coronavirus. We sent out an email to our colleagues, to all different departments, and this is, the Columbia network on the Upper West Side of Manhattan, all the way north to 168th are our colleagues at the Medical Center, the new Manhattan campus on 125th Street, and of course, most people are familiar with our Morningside campus on 116th Street. We have facilities throughout that network and colleagues and students and faculty spread out. So we put out our call, and we knew there was a demand for these face masks. We were somewhat concerned, trying to reproduce the N95 mask would be a significant challenge given the requirements for production. So we had multiple design meetings working essentially 24/7 in those subsequent 2 days, bringing together experts from all different departments, from engineers to scientists to clinicians, administrators like myself, as well as important is to tap into the procurement officers up at the medical center. We wanted to know exactly what kind of equipment they were looking for and various needs so that we can support them. And so when through those meetings, it was determined that the N95s were precious. And so how else can we support in protecting those? Because we didn't think we had the capabilities in-house to reproduce or 3D print an N95 masks. And what we've clearly learned is that one way to protect the N95s is to put them behind a face shield. And so we started exploring that, but the sheer volume they were asking for, you know, they were at that time looking for about 20 to 30,000 face shields a day. And as new patients came on, it would require about 70 face shields per patient. And the face shields were important, and they were somewhat used in order, like I said, to protect the N95 mask, which were so valuable. And the thing was, what was happening was there was major supply chain disruptions during this. So they could not receive these more N95 masks or face shields. So we had to come up with a solution. The sheer volume we recognize could not be solved by 3D printing. So we went through these design sprints to come up with alternative methods to produce face shields that we can supply in volume and be able to produce quick enough that they can meet the needs that our frontline professionals were facing. So we came up initially with 2 different designs and actually secured enough material to start making these in our maker spaces. And we had access to a water jet cutter that we knew can produce at least a few hundred masks a day. But we knew that wasn't a great solution, but it would at least get some masks and our face shields quickly up to our colleagues within a day or so. Next slide, please. Eventually, over the next ensuing couple days, we came up with a few other designs that were more 2D designs that we can work with contract manufacturers to essentially die cut designs out of sheets of plastic. And a die cutter is essentially like, the die cut method essentially is like a cookie cutter. You could put these sheets of plastic through a machine and it presses out to a specified shape. Luckily, we had some contacts with the plastics industry in Connecticut, reached out to a contact that I had, George Barletta at Plastic Tools out of Milford. He was able to restart his business that weekend, was able to open it up with protective gear for his staff. He actually had to call on a friend out of New Jersey to actually create the first production die. So he made his own trip out to New Jersey that weekend, worked with him in order to create the production die, brought it back to facilities. And the other thing that was important, because he had expertise and you know, decades in the business, he was able to secure enough materials for over a million face shields. And this was important because throughout the country, face shields became in demand. And so the plastic sheets were also becoming scarce. And so having someone who's been in the industry for a long time, he was able to secure enough raw materials in order to make the masks. And so 10 days later, we were able to supply New York Presbyterian with the first large order. And so 10 days went from that crazy email to producing 10,000 shields. And then he was able to ramp up his production to 40 to 50,000 a day. And just talking with George the other day, he has now supplied New York Presbyterian and throughout the Presbyterian network, over 600,000 shields. Next slide, please. And so we actually had a number of design teams. Again, these were material engineers, our faculty, our postdoctoral fellows, our staff, coming up with designs. Here's 3 different designs that we came up with because we heard from the front line that there are different needs for different procedures. And so the first face mask we came up with a simple 2D design, able to put over the face. The second one was a little, had a different type of strap that allowed for more comfort when putting on the mask and more adjustments depending on the types of needs and the types of procedures. And then finally, our third mask had more protection over the head, because as we heard with certain procedures like the intubation of patients, it required further protection over the eyes. And so we created a design which covered partially over the head, so you had almost a full covering of the face, including protection from virus falling into the opening above. Next slide, please. And what eventually came out of this was the establishment of the COVID Tech Innovation Group. And so we put together a team of engineers and collaborators at the medical center to really help professionals connect and collaborate to rapidly solve together the emerging problems of the epidemic. Next slide, please. And we knew our initial goals were to address the issues and challenges at the medical center, but now we're moving as the urgency at our New York City medical centers are starting to go down, which is great news, but we're now looking towards how do we get the economy started again. And we know there are many challenges facing us as we try to move back into the work and back into school. And those are things that the Tech Innovation Group is working now to solve. Next slide, please. And so here's the task force we put together. And again, it's taking expertise from all of our different departments, from our industrial engineers and operations research faculty, to our biomedical engineers, to our computer scientists, electrical engineers, mechanical engineers, and our data institute. This is being led by our Senior Executive Vice Dean Shifu Chang, myself, and Ivy Schultz, who runs our entrepreneurship programs. We have a communication teams who supports our effort to try to bring in as many volunteers into this process. And we have now over 600 volunteers who are continually working on projects that exist at the medical center, and now turning our attentions over to some of these societal disruption issues that we've been facing. All this information can be found on our webpage. Next slide, please. And we've also together developed a process for project intake and evaluation. So as at the front line, the clinicians were sending us requests. We put the task force to evaluating these requests and forming focus groups and eventually projects teams. And as we do with our students and as we teach our students the design process, we go through this iterative design process with those at the front line so that we truly understand the challenges they're facing in order to produce a product that they can use in the time that's necessary. And so the output of all these procedures and operations and activities are either products like you saw with the face shields, designs that we can share with others, or recommendations on how to approach the challenges they're facing. Next slide, please. So this has resulted in many different focus areas being explored. I told you the example of the face shields, but we've been also involved with our clinicians dealing with the idea of the ventilator situation. How do you multiplex a ventilator in order to get more than one patient on one single ventilator? How do you create bridge ventilator systems for patients who may not need the invasive intubation procedure, but need a constant supply of oxygen? So we actually ran a student design challenge to look at non-invasive ventilators. We've also heard concerns about the aerosolization of the virus during certain procedures like intubation. So we came up with designs for intubation patient boxes, which essentially cover the patient as the procedure is taking place in order not to spread the virus. We also are dealing with the issue of masks and how do you sterilize these and reuse them, because the supply chain still isn't up to a level that it needs to be. And this is a major concern as we start to open up the economy again. What masks are available and how do we keep them clean and virus free? And so we have a team looking at different approaches, whether that's heat sterilization or UV sterilization. They're also dealing with situations in the ICUs where you have multiple patients, and we just heard examples of converting many different ORs into multi-patient ICU units. And with that comes a lot of noise. You have a lot of different monitors on the patients, and it's very challenging to keep track of all those devices. So we have a team of electrical engineers and biomedical engineers exploring how do you create a system to monitor all those devices and get the necessary alerts out to the clinicians. And finally, turning to, remote work and remote education. How do we improve on online learning and online remote work? And we have our computer scientists working on different digital technologies to hopefully improve the process of education and work from remote locations. Next slide, please. And so I think you hopefully heard today how an academic institution can support these efforts. We have obviously world-renowned expertise in multiple disciplines. We, particularly in the School of Engineering, have taught and continue to have design thinking and problem solving on the tips of our minds when we come to thinking about what's all the uncertainty and how to handle risk. We have state-of-the-art facilities that we put to the test, both in maker spaces and our laboratories. We create a neutral environment to support diversity of thought and discourse over these issues. And obviously we aspire to sort of put these engineering products to use to support and service humanity. Just Columbia Engineering itself has 230 faculty, 9 different academic departments. We have over 3,000 students, all the way from undergraduate to PhD level, and the various accolades you can see. Next slide, please. So we hope you've heard today some of the heroic work that our faculty and staff, and working in collaboration both at the medical center and through our corporate connections, we're able to come to the rescue and support some of the efforts that were going on at the medical center. We hope to carry on this innovation group, and hopefully we could take the COVID out of our names and really turn it into a tech innovation group for all different needs. You may have heard in the past about our work on the L train tunnels, and we hope to continue to work with both government, corporate partners, and the like in order to bring innovative ideas and other ways of thinking to some of the challenges we're going to face going forward. So let's work together to build a better tomorrow. My contact information is on the screen, so please reach out if you have ideas or needs and you'd like to help. We'd like us to be involved in your efforts. Thank you very much.
Okay, hello everybody. My name is Brad Samuels. I'm a partner at C2. We're a design, research, and fabrication firm based in Brooklyn. And I just want to thank Nancy for organizing this panel. It's incredibly interesting to get this kind of behind the scenes view on these really fascinating and important projects. So thank you for that. You can go to the first slide. Okay, so I'm going to talk about a distributed testing strategy that we've been working on for the past month and a half plus, but also use it as an opportunity to kind of describe the anatomy of a pivot of our organization, how we've had to retool and kind of reimagine ourselves very quickly. Next slide. And this is the problem set, or part of the problem set that I think we're all familiar with, the kind of a deluge of patients coming to be evaluated in the early days at the front of hospitals. And the conversations we were having were very kind of ad hoc. I'm sure this was the case for many of you, sort of decentralized. And we got into sort of very quick, intense conversations with New York Presbyterian's emergency operations group. Next slide. And so on the one hand, you had the kind of queuing, those long queues, patients exposed to other patients. And on the other hand, you had medical staff having to evaluate those patients in sort of contained environments, right? And there was a lot of exposure there. So I would characterize the problem set as 3 parts. 1, how to mitigate exposure of medical staff to the volume of patients they were seeing, how to limit the exposure of patients to other patients as they waited in these long lines. And then 3rd, how to sort of cut down on the amount of PPE, which was so scarce, but really needed, right? So those are the 3 things we were trying to address in these conversations with New York Presbyterian. Next slide. But a few words on C2. We are trained as architects and we have a design office, but we also have a fabrication division. So our core ambition for a long time has been to sort of collapse the relationship between thinking and making, designing and building, sort of conceptualizing and realizing things, And this kind of put that ambition on steroids because there was a huge need to develop things quickly and implement them super quickly. Next slide. And we're working on this in our offices and our fabrication facilities in the Brooklyn Navy Yard. And I want to just point to the Navy Yard because it became a kind of ecosystem in the early days of the crisis, where many different tenants, some were making face shields, some were sewing gowns. And interesting, very, very important leadership. David Ehrenberg is the CEO of the Navy Yard, and he had his finger on the pulse of which tenants could do what, and also, was in meetings with City Hall, so what was needed, right? And it probably should be Ehrenberg's picture here instead of de Blasio's, but he was critical in connecting the dots, and we were one dot in that network. Next. And so we were taking cues from other things that had been done in other parts of the world successfully. This is in South Korea, these kind of evaluation booths that had been implemented there. You can see stethoscopes penetrating the kind of acrylic barrier that separates the medical staff from the people being examined, and someone cleaning on the left. And so, we were not the first to come up with this idea. There's examples in Israel, examples in India, some in different parts of the US. Next. But we kind of worked to take, the brief from Presbyterian and create a series of prototypes very quickly and deploy them. So here you see different prototypes being made on the right. We brought those up to the Columbia Presbyterian campus and had user testing with medical staff and got feedback. So this idea of, coming back, making a 2.0, 3.0, et cetera. For example, the gauntlet gloves that you see here, should those be fixed? Should they be more like an iris port where you can take your own glove and stick it through? How do you decontaminate all of that? Those were questions which needed to be prototyped very, very quickly. Next. And then also to kind of address the queuing question, how do we think about the check-in point and how people get to the booths? And here you can kind of see the idea of the separation between medical staff and the people that are being screened. The idea in the tent is that it's positive pressure and that area is relatively clean. So that's where, perhaps you can use less PPE. Question of how much is something for the medical staff to determine, but it can significantly cut down on costs when the alternative is changing out of PPE every time you evaluate or test somebody. Next. But as we're working on this prototype, which was originally targeted at evaluation, how to check heart rates and temperature and things like this, what also became really clear was that this, and as we all know, this is a phenomenon that is affecting different populations differently and some very disproportionately. So it became incredibly important. What you're looking at is infection rates in different parts of the city. How do we design something that is quickly deployable and can be moved to places as needed? It's not a one-size-fits-all approach, and that translates into a design strategy. Next. And so the question of evaluation quickly moved towards the questions of testing as we look at the horizon. How do we ramp up to even address the volume of testing? And this is 2 weeks old at this point, so it's ancient history. But the problem set is basically still the same, right? These evaluation booths went from evaluation to sort of being more useful for testing. Next. And then how do they get distributed? If these lines are forming in front of centralized locations at different hospitals, like Elmhurst Hospital, for example, is there an approach that could be more of a kind of satellite approach that could distribute these more freely in more parts of the neighborhood with lighter footprints and reduce the line and the volume and the throughput at any one specific place? So we kind of shifted to a sort of jump scale from the physical prototype all the way to the scale of the kind of urban question. Next. And began to imagine different types of sites, right? Could they be parking lots? Next. Basketball courts, neighborhood parks, plazas, et cetera. And in each case, imagining the queuing and the kind of architectural typologies, which you see on the bottom in different arrangements, all kind of light footprint, mobile, agile approaches. Next. And then at the same time, we were being asked to start looking at interior conditions as well. One of the things that was interesting is like how to do this without triggering building code compliance. They're kind of maintaining a gap between the plenum and the screening areas is one potential way to do that. But it was about speed, right? How to get these things done as quickly as possible. Next. And then, of course, the booths are just one part of a kind of ecosystem, an infrastructure that's necessary to carry this out. the data management, of course, workforce training and development in the kind of landscape of the economy that we're facing is really critical. And then test processing centers, how to get the samples to a place where they can be tested and the results returned really quickly. And so we're focused on one part, but we're part of a kind of network of expertise that is trying to deliver all of this. Next. And I just want to kind of conclude with, you know, as we all know, this has been focused on the kind of questions of public health and healthcare squarely. And, you know, we've since been asked by the Department of Design and Construction to look at interior testing centers with a firm called Jack Litch Gardner. So we're working on that. Next. But it's really spreading out into other sectors. So we're also being asked to redesign office spaces and how to create partitions to create safer spaces within work environments. Next. As well as with schools. So how to get people safely back to school when that's possible. So it's spreading out and touching a lot of different things. And I just want to kind of conclude. I think some people have spoken about the kind of types of collaboration, the levels of collaboration. It's been incredibly exciting. It's all to come together at this moment. But I also want to point to another thing, which is I would characterize the kind of productive tension between iteration and innovation on the one hand, and the speed at which it had to happen, and the kind of the need to minimize harm that is the cornerstone of medical ethics, and those two things kind of coming together in a kind of productive tension. And of the things we think about that we want to retain from this experience and move forward, those two things come to mind. So thank you very much.
Good morning, everyone. My name is Bill Allen. I'm a Senior Vice President with Hunter Roberts in the New York market. And just a tremendous, from a personal point of view, just wanted to say, just to know so many of you on this call, and just a wonderful effort by all of you. Absolutely fantastic. And just to thank Nancy and her team for letting Dan and I come on here this morning and share a bit of our story with you. So as we all know, you know, the pause that was instituted by the state of New York meant that, you know, the vast majority of our industries were closed down. In the construction industry, some were deemed essential, projects were deemed essential, some were not. So we had a mixture, as most of our peers had, we had a mixture of projects that were open and some that were closed. So what I wanted to do this morning, just if you'll indulge us for a few minutes, we had several projects that were continuing, and we had several projects large projects, what we needed to put a plan in place and figure out how we were going to go back to work safely, take care of the workforce, and just do that the right way. And Dan Halajian, who is a project executive with Hunter Roberts, has a tremendous client that he's working with at Long Island University. Dan has the privilege of having several hundred workers to contend with on that project. And I thought it would be useful to share Dan's plan that he put in place, and some of the lessons, quite frankly, that he learned along the way, and particularly to focus on a little bit of the technology, which is interesting to me, that's helped us get a good plan together. So with that, I thank you, and I'll hand you over to Dan Halajian.
All right, thanks, Bill. I appreciate it. If we could jump to the next slide, please. One more, thank you. So so as Bill mentioned, I'm a project executive. I'm working on a 34-story project, 600,000 square feet. We were about halfway complete with superstructure when the pandemic hit. We were running 300 workers on site, and our project was able to quickly get through the DOB process of essential status due to our affordable housing component. And like many others on site, we were kind of tasked with how do we keep the job site moving? How do we continue to deliver for our clients, allow workers to come to site and provide for their families, but also how we maintain the highest levels of safety on our job site in doing so. And we have kind of 4 key areas that we've identified that made us successful. And I'll touch on each of those in a little more detail. But pre-planning, like everything else we do with safety, we believe it starts with having a well thought out pre-plan, and COVID is no exception. Accountability from everybody on site to buy into the plan, from ownership level to the CM to the subcontractors and the individual workers on site. Having a strong and robust preventative care program. At the end of the day, we're dealing with a virus that's transmitted by close contact or by commonly touched surfaces. So preventative cleaning and sanitizing is extremely important. And then lastly, as Bill mentioned, I'll touch on technology. Some of the programs that we are using have really been able to adapt themselves to COVID. And there's some exciting programs that we're utilizing on our projects that we'd like to share. So if we could jump to the next slide, please. But starting first with pre-planning. So as I mentioned, having well thought out pre-task plans from ourselves and the subcontractors on site is extremely important, making sure that everybody acknowledges and understands the latest guidelines, and then really focusing on social distancing. And that's where we've gotten the most benefit out of these pre-task plans, is working with the contractors and our teams to kind of put our heads together and figure out how we introduce barriers or mechanical means or other ways to perform activities on site where we can do so utilizing social distancing. And then in terms of ourselves as the CMs on site, we've introduced a lot of new controls and programs to deal with COVID-19 and social distancing, including temperature readings, where we're partnering with EMTs to use non-contact thermometers and take everyone's temperature and complete questionnaires prior to starting the workday, introducing visuals and signage on site, and social distance markings at all the places where we used to have lines formed, such as hoist cars and temperature reading areas and loading docks. Really rethinking how we set up our work days and our work shifts, and kind of rethinking everything on site in terms of rotating our own staff, working with our subcontractors to create new shifts. As I mentioned, we were working on concrete superstructure, and we've kind of partnered and worked with our team to kind of do that in a new way and introduce shifting into our superstructure subs workforce, from his own carpenters, lathers, and masons to all of the other MEP trades working on the deck and offsetting shifts for setting sleeves and conduits, where typically we would kind of have all those operations working at once on the working deck. And like I said, really rethinking everything, project meetings, when folks are taking coffee breaks and taking lunch breaks, and those types of items. We've also had to refocus on rethinking our vertical transportation program throughout the site, our hoist program in particular, how we limit use of the hoist and kind of set up shifts for that, but then also how we introduce physical barriers onto the site. There's some photo there of how we introduce either plexiglass barriers or curtain barriers into our hoist, and making sure, again, that we're limiting capacity, that workers are facing the outside open air side of the cars as they're utilizing the hoist. And then similar with our stairwells, where we've introduced up-down programs into our stairs, and of course PPE and focus on gloves and face masks and face shields. Next slide. So accountability, I'll touch on this briefly, but obviously the plan doesn't work unless you have everybody's buy-in, and that's at all levels, whether it's ownership, construction manager, subcontractors, and down to the individual workers. We like to use the term that everybody is a lifeguard in the pool. And what that's all about is making sure that the workers realize and kind of buy in that they're responsible not only for their own safety, but for everybody else on site. And what's really interesting or important in this new COVID environment is that it's not just the on-site activities, but it's also kind of how everybody's personal life and making smart decisions outside of the workplace to keep everybody safe. So we've really kind of focused on getting the workers to buy into that and making smart personal decisions in terms of utilizing tools and bringing in their own lunch and how they transport to or from work and those types of items. Next slide, please. So as I mentioned, preventative care is obviously a very big piece to this puzzle. We've set up daily preventative sanitizing throughout the day a rotation of all of our common touch points and common areas on site, turnstiles, PPE, shanties, subcontractors' shanties, guardrails, handrails, those types of items. And then at night, we do a more robust preventative cleaning program, kind of what you see pictured here with spray machines and fog machines, and again, hitting all those common areas to prepare for the next day. And then utilizing hot water hand washing stations on site. And then in areas where, like our working deck, for example, where we can't yet distribute hot water, we utilize sanitizer stations, areas like the work decks and the stripping decks, and then follow behind as the project's built with distributing more hot water. And then lastly, if we could jump to the next slide, I just wanted to touch on technology. So there's a few programs here that we're utilizing, as I mentioned, that we were utilizing prior, but have really adapted to COVID-19. So when the workers come on board, we kind of sit and explain to them the benefits of these programs. It's not about trying to invade their privacy or anything like that, but really about utilizing these programs to collect data and utilize that data to keep our job sites safer. So a few programs that I highlighted here. AeroSite is a safety camera auditing program that we use. We have safety cameras posted throughout the job site. They take footage during the day. At night, that's uploaded and reviewed by an independent auditor who's tracking any safety observations. And we've been able to tailor that to COVID and reviewing for social distancing and face masks. And the next day, we have a detailed report with links to video footage where we're able to kind of utilize that as a training opportunity for all the workers on site. Skill Signal, this has allowed us to go paperless with a lot of the items that we previously would use paper for. It's an app that all the workers download and we're able to utilize for our safety orientations, distributing of safety memos, utilizing questionnaires and those types of items. Triax, which is about proximity monitoring. It only tracks proximity or location when workers are on site, and it's a proximity tracker that they'll put either on their hard hat or clip to their tool belts. And this collects all the data of where workers are working throughout the day. If we ever got into a situation where we need to use contact tracing for a confirmed case, we have the data of exactly who was within 6 feet of each other. And you could also set up alerts or notifications in real time for workers that are within 6 feet of each other. And then lastly, there's a few programs like this. Rich Tech is one I highlighted here. It's a stand similar to an iPad that we use on some of our smaller jobs where we don't have medics on site. And they have built-in thermometers and face scanning technology that allow us to still utilize our temperature control programs. So with that, I'd like to thank everyone for their time and be happy to answer any questions. Thank you.
Well, to all of our panelists and presenters, terrific. It is really impressive to see what our members and our fellow citizens in New York can do in the time of crisis. Having been part of several of the teams, it was most impressive to see the level of collaboration, which in my short 43-year career, I haven't seen to this degree or extent. And it really goes to show that when push comes to shove, New Yorkers can really rise to the occasion. Nancy, you want to start with the questions? I know we have had at least one come in.
Yeah, so that would be great, Mitch. I just also want to say thank you to all of our speakers and members for presenting these projects. This, you know, what struck me as you were talking was the scale and speed of the response was just astounding. And, you know, like, can you print 1 million masks this weekend? Like, just, you know, that's just overwhelming. And the fact that everybody came together and got all of this work done in such a short period of time is really miraculous. So, Mitch, you want to open it up with the first question?
Well, the first question is from John Ha. Was COVID-19 testing and tracking done for the project team members both during and following the projects? And could you share any of the results? And that's sort of open for all the teams.
Well, the SUNY Stony Brook site, they had regular temperature testing when you came into the, I would call it the command zone. The command zone for us was the gymnasium. But after that temperature scan, it was really good practice. Everybody had their masks on. There were big jugs of hand sanitizer all over the place. And everybody obviously kept social distancing measures in place. So it was good practice. They had folks walking around with I guess, bottles of Clorox and wiping things down on a continuous basis. But I think overall, it was just really good practice.
Chris, I would add to that we, in addition to the temperature taking, we added a brief questionnaire, and also we did a visual check. I mean, if somebody was hacking away or something didn't look appropriate, we took further steps.
Terrific. Any other contributions? A question for Hunter Roberts. The safety precautions that you showed us, the technology that you employ during the COVID-19 crisis work, what if any of that is translatable now for firms to be able to go back to work? What should be the technology that could and should be employed for all of us as we re-envision going back to our offices?
Yeah, so I'll start there. So I would say with all the programs that we've highlighted, we've gotten a tremendous benefit out of all of them. They all kind of serve, I'll say, a slightly different purpose. Some of them are more about kind of being proactive and getting ahead of it. And then others, similar to Aerosite and the auditing program, are really about, on a daily basis, lessons learned and kind of tracking, okay, here's all the work that was performed yesterday, here's the observations where we can improve upon social distancing, or here's where, we saw a worker take their face mask off to scratch their face or something like that. And so I would say we've gotten benefit out of all of them. I like to highlight that Aerosite program because it's one thing when you kind of have these safety meetings and you're kind of talking about something that somebody saw on site, and it's a very different feel to it when you're able to have links to the video and kind of use that as a training opportunity for the workers. So I would say we've gotten benefit out of all these programs. Most of these programs, like I mentioned, are programs that we were utilizing anyway for other safety reasons that really have adapted themselves to COVID-19. So as a company, I envision us utilizing these programs for the foreseeable future. I don't see them going away even after hopefully COVID, starts to hopefully go away. We'll continue to use these programs.
Terrific.
Bill, it strikes me that, some of the solutions touch on broader social issues. And one of those is privacy, personal privacy. And the tools that you're describing, feel intrusive. How are you dealing with that with your employees?
Yeah, you got to be careful with that, and I think it's all about being fully transparent and open. Any tools that we use at all on any of our construction sites, excuse me, are done in an open, transparent way, and we sit and talk and have all of that information available up front. To every single person who comes on the site is aware of it. They're aware of what it's for, why it's being used, and I'll let Dan tell you what kind of feedback he gets on it on his project.
Yeah, I think Bill, you hit the nail on the head there. It's really about day one, kind of sitting with all of the workers and trying to communicate why we're doing this, and the why is really important. And once you kind of get their buy-in and they actually see the benefit to it and realize that it's helping to keep the job site safe, that it's helping to keep them safe, we've gotten great results and great participation. So I think it really comes back to kind of how we touched on accountability, and all of these programs have been received very well. It's one thing I've noticed just in general on our job site in particular, and I'm sure others in the industry, kind of mentioned how everybody's coming together at this time. Like, we've really seen kind of no pushback on some of these. I mentioned a lot of different programs that we've introduced in off-shifting work and the hoist programs and temperature programs and things that sometimes you would feel like in a normal condition, you might get a little pushback because it does slow down productivity and does slow down a few things on site, but we haven't seen that in this environment. Everybody's really come together. All the workers are really just interested in keeping themselves safe and keeping their families safe. And it's been great to see kind of everybody come together and get their buy-in into these various programs.
Nancy, if I may, from the university's perspective, have a few words. You know what, we are a research institution, so as you're looking for long-term solutions and being challenged with this idea of privacy and security, we have a number of experts who are exploring this, and the COVID pandemic has already launched over 150 different research projects throughout the Columbia University network to look at these exact issues, from something that's very technical that could be applied, for instance, a therapeutic or a diagnostic, to these challenges, the social implications and the privacy and security issues that come with utilizing new technologies. And so we're looking for partners to collaborate on that. So if you have folks in your network that are looking to explore and ask these questions in a controlled environment under typical research or IRB procedures, we have those capabilities and welcome those opportunities to collaborate.
Yeah, well, it'll be really interesting as we move forward to see, you know, kind of in the broader social context, how these issues are addressed, because they're just coming up right now. And in the midst of a crisis, it's important to use them. But then what are the, you know, limitations on that? Where do they end? But Eric, you also have talked about new ways of working, in particular releasing intellectual property protections around your masks, which allowed these to be distributed quickly. Do you want to talk a little bit about that?
Yeah, absolutely. You know, intellectual property is something that we take very seriously at the university, but given the urgency and the critical need, we decided to, all of our designs for our face masks are available for access through a free click license during this situation. So we didn't want to hamper anyone's ability to get those designs and start manufacturing them. We don't manufacture, obviously. We're not an institution. We can you know, cut out or produce a few hundred, but at that volume, we needed to reach out to contract manufacturers like the one in Connecticut. We have a few others that have licensed the face mask that will sell at cost, essentially, the face shields to those who need it. So I think it's important, especially in this situation, to make this knowledge and these designs available to those who need it. You know, different technologies, you have different approaches, you know, and we'll have hopefully diagnostics and therapeutics down the road that will be useful in this campaign as well.
So Mitch, I think we've got a couple more questions from the audience. Do you want to take those?
I certainly would be happy to. The next question is from Mark DiNapoli. A question for the contractors. How have the building inspectors responded to site conditions on active projects? Chuck, you got unmute.
Thank you. Well, we've noticed when most projects were shut down and the healthcare projects were not, the number of inspectors didn't diminish accordingly. So there were a lot of inspectors visiting fewer sites. And initially, you know, my reaction was it seemed that they were questioning why some of our projects were working. They were very, very tough. They were visiting jobs daily, sometimes twice a day. In the past, maybe it was once a week. So we definitely had a lot more visits. But once they saw that the protocols were in place, that we had a good screening procedure, we have a the orientation process, and the entrance to the site is set up with thermal scan. There's a medic, there's social distancing, there's a questionnaire that Rich mentioned, there's a visual check. And very quickly, they saw that the line out the door was very equally spaced. The workers were acknowledging the effort. So they started to back off a little bit. They do come on site. They have not issued any violations, luckily, because some work conditions are tough to socially distance. We are limiting the number of people in hoist and elevators to only a couple. So we're asking workers to take stairs one way up and a different set of stairs one way down. When there are certain tasks that require, close proximity, we're making sure that they have the proper PPE and not just a bandana. So, they have been a lot more focused, but they have not issued any violations, but they are watching. There's no doubt about that.
Yeah, Chuck, this is Chris. I totally agree. Having an active healthcare project, they're actually a little bit proactive, and possibly because this is a public hospital, they've actually been helpful, but they've also not given us a violation. They've been impressed with the protocols and the technology in place. And yeah, knock on wood, we have not had a violation to date. And they are visiting very often because you're right, they've got nowhere else to go.
Yeah, we've seen similar on our end. Just to add on, we've had the DOB on site pretty much on a daily basis. And as Chuck mentioned, a few times, twice a day. But similar, that they're checking that, kind of all the things I went through, and others have echoed, that these are in place, that it's being taken seriously, and then they've kind of partnered, I'll say, to an extent to make sure that these programs are in place and make sure that the job sites are being safe.
Great. So the next question is from Mark Mohammadi. It's really a follow-up, and I'll put a little different spin on it. And the question is, how are the BOB filings and approvals and health department inspections expedited to given the urgency and speed needed? I do know, having worked with several of the teams and the DOB allowed these projects to be done on an emergency basis, which basically is you didn't have to get a permit before you did the work. They allowed you or permitted you to start work and then file within the next couple of days to get the paperwork. But they made reasonable attempts to help expedite, given the extreme urgency of a lot of these projects. Chris or Chuck or Rich, any of you want to add to that? I mean, I certainly saw it from our end.
Yeah, I would agree, Mitch. A lot of the work that we're doing is electrical and plumbing in nature, and there are provisions at DOB for expediting that type of work in particular. But yeah, they've been understanding and cooperative in getting us started and moving it along and then signing it off at the end. They've had no issues with anybody getting in our way to start the work. And in fact, they've been cooperative in pointing out processes that'll help us do it faster and get it permitted.
So Nancy, that concludes the submitted questions, and I can see from my my clock that we've pretty much run out of time. So I will turn it back to you.
Thank you, Mitch, and thank you again, all of you. I would just like to close and get some very brief thoughts from you on, we've heard about all the lessons that you learned in this crisis. So how do we apply these lessons that we've learned to help build a better tomorrow, as Eric said? How do we take the new ways of working, the new technologies, the new tools that we've learned and apply them to the problems that we're facing in the future?
Nancy, I would just say quickly that, again, it's a bit of an intangible, but the level of cooperation cannot be overstated. It was something that absolutely made a difference in every single emergency project that we did. The majority of the people on this board and this panel were those people, along with countless subcontractors and vendors. And if we can take that conscious decision that everyone made to take the high road, and we take that to the next project, I guarantee the results will be similar and successful.
Yeah, Nancy, this is Tony. I'd also like to throw in addition to Rich's comments, the design build process. We see it periodically. Every one of these projects was design build. And, it's the collaboration of the engineers, the owners, the contractors, the subs coming together, and you asked, what can we take away from this? When the project's out there, we see the results that can be accomplished when you bring everyone together, put them in the same room, and give them a goal, and the best ideas really rise to the top with the best players.
I want to just piggyback
build
on
in
that
flexibility. I'm sorry, go ahead, Brad.
Yeah, I was just going to say, I want to piggyback on the design build observation. I think, we have this idea when you put architecture and built environment to the world, it's static. I think we learned a lot of lessons around sort of what we usually call post-occupancy analysis, this idea that you can get user testing and feedback that can then be brought back into projects in real time, and there's intelligence there that can improve things moving forward. So that's for us, a big takeaway.
Absolutely. Flexibility, do some of the small things, drag an extra emergency circuit, upsize that branch distribution oxygen pipe by one size. These little measures mean a lot and can accommodate more patients.
And the last thing is trusted partnerships, I think, is the key to all this. We're all trusted partnerships to make these projects work.
Absolutely.
Great. Well, thank you, everyone, for everything you did to get us through this crisis. And hopefully we'll be able to use these lessons and tools moving forward, and really appreciate your participation this morning. Take care.
Thank you.
All right. Appreciate it. Thank you.
Bye-bye.
Bye-bye.